me that if I prefer to discuss some other topic, I am quite free to do so. I have decided to go ahead with this one, however, even though it is not one I would have originally come up with, because in my opinion it has too negative a kind of tone. But I choose to go ahead with this one both because I have collected my ideas over the recent months about this topic, and because the very negative quality of the topic lends itself to the first point I would like to make. Schizophrenic patients who are so very unsure of their own humanness and so unaccepting of themselves tend to make the therapist feel terribly critical of himself, terribly unaccepting of himself insofar as he does not function in an omnipotent kind of fashion. That is, the patient tends to give him to feel that he must be omnipotent in order to meet their needs. He must be omnipotently loving and accepting and capable. And insofar as he finds himself quite the opposite, as one surely does find oneself much of the time in working with schizophrenic patients, the therapist then tends to be violently rejecting of himself. Thus, it would be, in my opinion, most regrettable if one enters into this kind of work in a spirit of trying somehow to avoid making errors, for errors surely are inevitable, many of them in any one session one has with the patient, no matter how much experience one has had. Moreover, to a considerable degree, what might seem an error for one therapist is a right response for another therapist, a right response in which he is being true to himself and accurately conveying the reality of his own individual self to the patient. One can say that the more accepting the therapist is of himself in all his human fallibility, the more able he is to be of help to the schizophrenic patient who so much needs a relatively self-accepting human being with whom to identify. I'm still continuing with the first kind of topic I want to discuss here. The schizophrenic patients I have seen seem to fall into two general categories as regards success. There are those who have known very little of any conventional success in their lives, those who have done poorly in school, poorly in any of the conventionally designated areas of success in our culture. For such a patient to be working with a therapist who has known very much of conventional success and who seriously thinks it's possible to be infallible and has to quite an extent been able to maintain the illusion that he has throughout his years thus far functioned in a relatively infallible way, the patient cannot find in such a therapist enough of a kindred person to be able constructively to identify with him. Then there is the other kind of schizophrenic patient, probably much more frequent, who has had up through his youth a considerable degree of success in the things that our society counts as important. That is, very frequently these patients have done extremely well in school and have been model children, so-called, and when they encounter the therapist who is a kind of model of success, who has done well in school, as most any physician more or less has, the patient tends to have little use for those qualities in the therapist. For the patient himself has long ago become disillusioned with such conventional success, and he needs a therapist who can come to know what it is to feel himself to be a failure, to know despair, to know all too much of human fallibility and error. I am here again simply emphasizing that the more one can work in this field in the spirit of acceptance of the inevitability of human error, the more capable one can be in being of real help to the patient. Some of the young therapists whom I have admired most are those who are able to go ahead working with a very discouraging chronic schizophrenic patient in which setting the therapist comes to see clearly the unconscious defensive functioning of his own, you might say, character armor of success, so that the therapist, who has been used to very much of success in his life, in college, medical school, and so on, or graduate school of whatever sort, can come to know what it is to seriously doubt his own competence, to question the meaning of his life and his own usefulness, and to be able to go ahead working with the patient and appreciating thus the patient's own despair and futility, and the therapist and patient being able to find meaning in their work together. Just as the schizophrenic patient, who has known so much of failure in his life, could not find in an across-the-board successful therapist a realistic figure with whom to identify, so I have seen innumerable times now that the therapist, in feeling sadistic toward the patient, as inevitably happens much of the time, can be reassured on the grounds that if he were somehow free of sadism, if that were humanly possible, the patient, the so sadistic schizophrenic patient, and in my experience every schizophrenic patient has a great deal of sadism in him, could not find a person with whom to identify in the therapist. That is, if the therapist were able to be across the board loving and free of sadism. Furthermore, still in this first area of discussion, one quickly comes to learn in working with these patients that any kind of response one makes to the patient is in a sense erroneous, in that it does not meet the patient's need, one might say, just looking at it now from the viewpoint of the patient. And this is so by reason of the very pervasive and intense ambivalence on the patient's part. This ambivalence is largely at an unconscious level, quite different from the neurotic patient, who is able to be more or less aware of immediate emotional conflict, that is, able to know that he is wanting this, but on the other hand he is at the same time wanting the opposite of this. The schizophrenic patient has not enough ego strength to be able much to be aware of intense conflict in the present. Instead, what he is aware of is that he is wanting wholeheartedly something very strongly from the therapist. And if the therapist does make a response that is at all designed to meet that need, the very opposite and intense wish in the patient's unconscious is to that extent frustrated. That need is not being met, so that the patient is left feeling dissatisfied, frustrated, and is giving the therapist to feel that somehow he has not met the patient's need. That is, the therapist comes to see that, in a sense, he is damned if he does and damned if he doesn't, to use the cliche. And of course, from a genuinely psychotherapeutic point of view, what is needed in these situations is any response that will foster the patient's gradually becoming more and more aware of the fact of his ambivalence, the fact of his having conflicting feelings. The second area of discussion I want to take up is the common error of believing that if the therapist finds himself experiencing intense emotion of whatever sort toward the patient, that this is evidence of an unacceptable and unwanted kind of countertransference in the classical sense of the term, namely something brought into the treatment from the therapist's own unexplored past, in which he is reacting to the patient as though the patient were, for example, the therapist's mother or father, without the therapist's realizing that this is the case. One of the major reasons why a personal analysis is so very desirable a thing for the therapist to have is that the analysis, insofar as it is successful, makes all of the therapist's own emotions much more accessible for his own use, and he very much needs free access to all his emotions of whatever sort for this work with the schizophrenic patient. Early in my own training, a kind of nonsense used to be promulgated that in one's own training analysis, one hopefully would become free of certain unpleasant emotions such as envy or jealousy. I cannot emphasize more what nonsense I feel that to be. And on innumerable occasions, I have been able to help schizophrenic patients, for example, by freely indicating to them that I found myself feeling envy of them or jealousy of them or whatnot. And this, more and more, one can come to know is a very relevant reaction in oneself to the patient, whatever the feelings one may be having. The more one has had occasion to explore one's own past, the more one can be aware that one felt this way toward mother or father or whoever in one's past, but that there is real and realistic reason to be feeling so toward the patient, and one's own feeling toward him or her is relevant data which the patient needs to have. All this particularly needs emphasis as regards working with a schizophrenic patient, because there is a kind of myth about such patients that they are so very precious and that one should feel toward them nothing but tenderness, love, delicate kind of feelings. In part that is true, but one needs ready access to quite different kinds of feelings, much harsher ones also. Not long ago I presented my work extending over 7 years with a hebephrenic woman, and described in a paper on that subject quite intense feelings of a wide variety of sorts that I found myself experiencing toward the patient. At the end of the presentation, one of the members of the audience asked, "What about the countertransference?" Well, this was asked in a chiding tone, as though all these more intense feeling experiences had been evidence of unrecognized countertransference on my part. This was typical of the kind of chiding and reproof that I had to work against in the early years of my own experience in this field. I am not meaning here to imply that a therapist should put off doing any work in this field until he has had a personal analysis. I do not go that far. I have seen some excellent work done by young therapists who had had no analysis whatsoever, but who were more accepting than most of us of their feelings of sexual attraction toward the patient, their feelings of anger toward the patient, and so on and so on. Still continuing in the same area, the psychotic patient, schizophrenic patient, has such an intense transference reaction to the therapist, so many multiple transference reactions really, and so powerfully projects by the same token upon the therapist his own unconscious feelings, the patient's own unconscious feelings, that it is very important that the therapist be able to be aware of the reality nuclei within himself, which form the basis for that which is being projected upon him. Freud, in one of his papers on paranoia, jealousy, and homosexuality, I'm not giving the title quite accurately, but one could readily find it, emphasized, and I've quoted this in my book of collected papers, emphasized that the patient does not project upon the blue sky where there is nothing real already as a basis for the projection. That is, one can say that there is always some reality basis for a patient's perceiving one in what we call a distorted or exaggerated way. Thus, if the patient sees the therapist as being murderously inclined toward him, it is very important that the therapist be able to be aware indeed of murderous feelings in himself, although hopefully well within his control. But if he has to remain unaware of any such feeling toward the patient, he regards the patient's view of him as quite totally delusional, and this he cannot, in that sense, help the patient. The patient, in a sense, behaves in a way that tends to make his own transferences real. He tends really to reconstitute, to a striking extent, the interpersonal world of his childhood. And if the therapist cannot be aware of some element of reality in himself, that he is indeed, that is, feeling toward the patient, something as the father or mother presumably did, then the therapist and the patient tend to be stuck at that point. As an example of what I'm talking about, a huge Amazonian hebephrenic woman whom I was seeing in her seclusion room said to me one time, she walked over to me and said to me, "Dr. Searles, why do you hate me?" This was said in an apparently entirely unhateful way. She showed no sign of being aware of any hatred toward me, and I was not aware of any feeling of hate toward her. And I got hung up on this. I got thinking, well, I suppose I do hate her, but I couldn't think of anything more than theoretical. I wasn't aware of any real hatred of her. And this is an example of how powerfully she was projecting upon me her own hate. This woman had made a number of attempted violent assaults upon me. She had an hallucination one time of a row of exploding teeth going up one side of her room and across the ceiling and down the other side. That's the manifestation of the enormous unconscious rage there was in her. She had given me much reason to hate her, and unfortunately, at that stage, I was not sufficiently accepting of my own hate, so that it would have been better had I been able to, when she asked me that question, to be able to feel quite in touch with my own hateful feelings toward her, but not to get hung up on that, and to be aware of her projection, the fact that she was so fully projecting upon me her own hate. One of the patient's very typical transferences is to the therapist as being a parent who is helpless to function as a parent at all competently. And the patient functions in such a way toward the therapist as to give so very much of reality to this kind of perception, and tends so much to make the therapist feel realistically and pervasively helpless, such that it is very hard for the therapist to get a perspective on this and to see the transference element in that reaction. Again, the value of personal analysis in this regard helps one to be more accepting of one's own feelings, in this case of helplessness and futility, so that one does not get, as I put it, hung up on them. One does not keep trying to stave them off, trying not to acknowledge such feelings in oneself. I am not very good at accepting that kind of feelings myself, and I wish I were more able to accept them. But the more one can be accepting of them, and to see that realistic aspect of the patient's perceiving one so, the more one is able then to get more perspective on it and see where this links up with the patient's childhood, and with the fact of the mothers or fathers having been unable to function very competently as a parent to the patient. And by the same token, the more one is able to get a perspective and see to what extent the patient is projecting upon the therapist her own feelings of futility and helplessness. In brief, I have found it very helpful to think of both the patient and the therapist as containing, in a sense, a sample of everything. That is, from the therapist's point of view, over the course of treatment, he can find in the patient a sample, one could say, of something to envy, of something to be jealous of, something to adore, something to hate, despise, to want to emulate, and to identify constructively with, and similarly from the patient toward the therapist. Thus, over the course of treatment, from the therapist's point of view, he will have genuine and reality occasion to feel, at one time or another, the whole gamut of human feelings toward the patient. And this is all very different from what at least I used to be taught, that any intense emotion felt toward the patient, of whatever sort, was wrong, was out of place, was evidence of a bad so-called countertransference. One can say that surely the more fully aware the therapist can be of whatever feelings are going on in him from one moment to the next is desirable. It is in a sense quite another question as to whether and when and to what extent and in what manner it is well for him to convey these feelings to the patient. That is so very complex and difficult a question, about which really it is quite impossible to prescribe anything. I can say that for me, having had certainly in previous years a more obsessive-compulsive personality than any other kind of neurotic one, I have tended to be much too cautious about expressing my feelings to the patients. The more one can be be responsible for one's own feelings and not have to burden the patient with the responsibility for them, the better it goes. For example, when a patient said to me suddenly in the midst of a rather close interchange with me, she said, "Did I just have a litter of Cocker Spaniels by you?" And I laughed and said, "No, but it's a delightful idea." This clearly did not hurt her. Whereas with another patient, I confessed to her that I had had a sexual dream about her the previous night. And she had shown nothing in that particular moment of needing any kind of acknowledgement from me of sexual feelings toward her. This came to her out of the blue, and after the hour, she smeared the wall of her seclusion room with feces. This was one of the relatively infrequent manifestations of her most intense anxiety, a clear indication of how much it had upset her. Similarly, with another patient who showed a great deal of terror much of the time, in one session in my office, when things were somewhat quieter between us, I told her that I found myself wanting to take her on my lap and comfort her. She immediately ran out of the office in great alarm and yelled at the top of her lungs, "Is there a doctor in the house?" With another patient who had been enormously provoking to anger in the hour, I finally told her, pretty much through gritted teeth at the end of the hour, that I had been feeling throughout most of the hour like beating her to a pulp and then beating the pulp. She replied in a very relaxed way, "Why didn't you say so?" It seems to me these things have to be on a somewhat trial and error basis, and one is on relatively solid ground to the extent that one is reporting to the patient feelings or fantasies one finds oneself having, while maintaining a very large-scale responsibility for the feelings, rather than in a confessional spirit burdening the patient with the feelings. And one is on solid ground when the patient is clearly needing acknowledgement from one, that one is feeling thus and so toward him and her. And if one finds that one is, this can be given as a kind of corroboration to the patient of his or her reality testing. Another common error in the psychotherapeutic management of schizophrenic patients is the overuse of drugs. I cannot say that I am flatly opposed to all use of drugs in this field, although I do not use them in my treatment of patients. I can say that in my general observations of very many treatment situations in which drugs are being used, that more often than not, the use of these drugs tends to obscure and dampen down the feelings in the patient, that very often therapists start their patients on drugs really basically as a way of sparing themselves, the therapists, from a recognition of their own intense and ambivalent feelings toward the patient, feelings which are so much inherently a part of what needs to be worked out in the therapy. Further, it seems to me that it greatly increases the difficulty for the patient to work through his hostile feelings toward the therapist if the therapist is in the position of, in effect, breastfeeding the patient by giving the drugs. Every psychiatric resident or person of comparable level of training certainly should have experience in working with at least some of these patients without utilizing drugs. I can say from my own personal experience over and over that there is something immensely strengthening and reassuring and confirming of oneself about finding that one can work with the patient through very difficult times without relying upon the crutch of drugs. And surely such experiences greatly enhance the patient's self-confidence and feelings of being able to rely upon himself and upon his human therapist rather than upon these non-human drugs. The next major point I want to make has to do with the fallacy that the schizophrenic patient is thoroughgoingly fragile, that he has been subjected to a childhood so hurtful and traumatic and is now left so devastated that one must deal with him only in a very tender, nurturing, delicate, meticulously careful, extremely sensitive fashion. In short, this fallacious view of the patient very much overlooks the extent to which the patient's illness has a very active, dynamic interpersonal meaning, in terms of which the schizophrenic patient, through his symptoms, is, whether consciously or unconsciously, very sadistically constricting the therapist, controlling the therapist, and one might say brutalizing the therapist with the patient's supposed fragility, strangling the therapist with the patient's supposed fragility. When I began in this field, I found that there was a widespread belief, for instance, in the outpatient clinic where I used to work, that schizophrenic patients could not stand being seen frequently. This, I long ago came to understand, actually has more to do with the therapist's problems in enduring having several hours a week with a schizophrenic patient. The patient himself always has formidable defenses which enable him to stand being seen more frequently. That is, the schizophrenic patient can always tune out, as it were, into a fantasy world if need be to get through the hour. The therapist is less able to stand such a degree of autism. The matter of the schizophrenic patient's ego strength is a very complex matter, and I frankly do not feel that I am sufficiently clear about this to be able to make some very succinct statement about it. But one way in which I have found it useful to think about it is that the schizophrenic patient functions actually in an enormously powerful way vis-a-vis other people, and is terribly helpless in face of himself. The patient, as I shall describe a bit later on, is relatively unaware of very intense and complex and conflicting feelings, and instead, through perhaps some conscious but more largely unconscious mechanisms, very powerfully instills those feelings into the therapist instead. That is, the therapist feels the more or less full burden of experiencing the feelings which the schizophrenic patient is successfully defended against. As I have experienced it, any one therapist needs to go through the experience with any one schizophrenic patient after another, over and over again, the matter of the therapist's finding himself increasingly constricted by and controlled by the patient's, so one perceives it, fragility. That is, one feels that one must not express one's thoughts and feelings at all freely to the patient, lest the patient become quite completely crazy, or lest the patient suicide, or very frequently lest the patient break off the relationship and never return. Another of the very frequent threats is that the patient will lose such a precarious sense of identity as she or he possesses. Always there is the connotation that were one or another of these catastrophes to occur, it would be entirely the fault of the supposedly so sadistic or inept or insensitive therapist. This work, in other words, very formidably, as I mentioned earlier in the talk, evokes the therapist's archaic, self-punitive components of his own superego. Another aspect of the patient's, what one perceives to be fragility, is that the patient looks so enormously vulnerable, without any skin or integument, one might say, to protect her or him against the usual traumata of life, so that one feels that one must be extremely careful in choosing one's words so as not to hurt the patient. And ironically enough, the very patient who is showing little or no compunction in saying and doing enormously hurtful things to oneself. One tries to keep the supposedly so fragile patient in therapy by making all sorts of accommodations to him, all sorts of variations in one's more accustomed ways of dealing with patients. And these accommodations one makes at the expense of growingly intense but still largely repressed rage, contempt, and rejectingness toward the patient. In other words, one infantilizes the patient, and this leads to an increase in the patient's paranoid reactions. That is, he naturally becomes increasingly suspicious of why is the therapist willing to go to such lengths to keep him in treatment. He naturally wonders what ulterior motives the therapist must have. And all too often, the patient with such an increase in paranoid suspicion flees from the treatment. This I regard as being in line with some of the therapist's repressed wishes, his feelings of rejection toward and rage toward the patient. And were the therapist more freely able to be aware of the rage and contempt and feelings of rejection toward the patient, such an outcome need not happen. Namely, the patient would not need to flee from the so repressedly rageful therapist. In these situations, the supposed fragility of the patient is, in large part, a projection of the fragility of the therapist's own defenses against his own repressed negative feelings toward the patient. After having done this kind of thing for long periods with any one patient, I will find myself coming to realize how enormous lengths I have gone to in trying to accommodate to the patient's, so I have perceived it, fragility. That is, for example, I will find that I have been avoiding saying various loaded words, avoided making sudden physical movements. I found myself saying little or nothing to the patient, lest he shatter. Have on occasion, with some of the more severely schizophrenic patients, found it necessary to give them orange juice, and in various fashions catered to them in ways which I now realize have become more and more onerous to me. One comes at such a juncture to feel a very healthy access, that is, a realization of rage at the patient for being so constricting and so demanding. Another way of looking at this supposed fragility of the patient is to see it that the therapist has been striving to maintain a fantasy of his own omnipotent lovingness and gentleness. This is an illusion, of course, a fantasy, and this fantasy is fragile, being threatened all the time by realistic feelings of anger, annoyance, contempt, envy, and so on toward the patient, as well as being threatened by the genuine ugliness of various aspects of the patient's behavior toward him. So very frequent a phenomenon in this kind of work is that both patient and therapist strive desperately to maintain a highly idealized picture of himself and of the other person in the relationship, and project onto others outside the relationship the more hateful and contemptuous aspects of their feelings. This is what is, as is well known, called a paranoid twosome. Gradually, as one does more and more of this kind of work, one comes to see how very rapidly the patient's levels of ego strength or of maturity vary, or there may be even coexistent levels simultaneously, such that one had best address oneself consistently neither to the adult aspects of the patient nor to the child aspects, but to be able to address oneself to this or that aspect as it is appearing. One of my patients responded to a comment from me which evidently was particularly useful to her. She responded with delight, "So you'll meet me on the 3rd and 14th floors," she exclaimed. It was as though my comment were meeting her where she felt the need at the age levels of both 3 and 14 simultaneously. Integrally related with this matter of the supposed fragility of the schizophrenic patient is another common error in the therapeutic management of these patients, namely the therapist's failure to work from the very outset on the basis of realistic setting of limits as to what he is able to provide the patient and as to what he will put up with from the patient. Therapy which is oriented primarily in terms of trying to meet the patient's needs is, in my opinion, bound to fail, for the patient's needs are insatiable, are extremely conflictual, constantly in flux, and the therapist cannot succeed in this work if he, as it were, throws himself into the maw of these conflicting, intense, insatiable needs on the part of the patient. It will only, as I've thought of it, make mincemeat of the therapist. On the other hand, the therapist in private practice, if he finds that his own professional life is such that it is simply not feasible for him to work with schizophrenic patients in a hospital, should make clear to the patient and, if necessary, to the relatives that if in the course of the treatment hospitalization of the patient should be required, the therapist will not be able to continue with the treatment in that setting. Likewise, with the matter of fee, I have seen many treatment situations in which the very guilt-ridden therapist has gone on and on and on with a course of treatment for which he is receiving much below par monetary recompense. But he feels unable to change this situation because he feels so to blame for the patient's continuing illness. If the therapist does, from the outset, work in a basis of realistic limitations as to what he himself can afford to do for the patient in terms of his own time, energy, and money, and the other demands upon him in his personal and professional life, this is, in the long run, immensely reassuring to the patient, for she has reason to know that she cannot destroy the therapist, cannot devour him, as it were. The great price for the therapist of being able to work in this realistically human way is that he must put aside his dearly cherished fantasies of personal omnipotence. The schizophrenic patient, more than any other patient, repeatedly holds out to the therapist the lure that if only he will function in a manner that will be gratifying to her and will be meeting what she feels herself to need, this will involve then the therapist's emerging as omnipotently loving, transcending all the other demands in his life, free at last from all such ugly feelings as contempt, rejectingness, hatred, rage, envy, and so on and so on and so on. That is an enormously powerful lure. I find it very valuable and freeing to come to see how legitimate it is for me to set certain limits that are adapted to my own particular style and likes and dislikes, to some extent irrespective of what my colleagues in this field do in the way of limit setting. Through such individualized limit setting that springs out of the individual reality of one's own life, one thereby gives the patient a chance to come into contact with one as an individual. In some regards, I am more tolerant than other therapists, and in other ways, I am much less tolerant. But if I function on a basis of limit setting having to do with my own particular tolerances and intolerances, the patient then has a real opportunity to get to know who I am. I have already said some things about the transference, and the next common error I want to describe is the failure to conduct the psychotherapy of the schizophrenic patient primarily in terms of his transference reactions to the therapist. I am an analyst by training and conviction, and I am deeply convinced that the best psychotherapy of any patient is an essentially psychoanalytic one, in which one's interpretations are best expressed in terms of interpretations of the patient's transference reactions to oneself in the here and now situation, with links to what one knows of the patient's childhood history. The schizophrenic patient in particular is so deeply ambivalent and tends so very much to unconsciously split the objects to which he is relating that he very powerfully presses the therapist to try to rescue him from the supposed villains outside the treatment situation. For example, I recently visited a hospital in my work as a consultant and interviewed the schizophrenic woman patient of one of the residents there. The resident was reacting to her as being essentially victimized by her, so the resident described it, coldly antagonistic, autocratic Army colonel husband who was breaking up the treatment by demanding that his wife be back home within a few days. The resident was clearly very angry at the husband. During my interview with the woman, it was evident that she herself, along with her pleading, victim kind of expressions of need for help, also had her own coldly hateful, autocratic, destructive to therapeutic collaboration kind of aspects, and it was evident that she tended to react to the therapist as being coldly hateful, much as she described her husband to be. The real enemy of the treatment was not so much the husband, but these aspects of the patient. An example from my own therapeutic work is a schizophrenic woman who had never completed high school, had worked only in a low-level secretarial typist kind of job a number of times, and had long been hospitalized. She had just been given a, in some ways, very menial job as a ward secretary, and she would come to her sessions describing to me, conveying to me, her terror of another woman patient on the ward who was indeed quite murderous, and of whom my patient was very afraid. My patient was afraid this other woman would kill her out of envy of my patient's having been given that ward secretary job. I had by now had much experience with this patient I'm describing, and was able to see that it would be quite folly for me to be drawn into trying to do something to protect her from the other woman patient. What instead became evident, that my patient had an underlying fear of me as a murderously envious mother. It at first seemed ridiculous that I would envy her for her having this ward secretary job, but in actuality there was some reality in that, since I felt quite isolated from the ward, both staff and patients, and had some reason to envy her the degree of acceptance she had achieved there. But more pertinently, in terms of the transference, her mother, who had never worked in any capacity outside the home, could well be seen as having a great deal of murderous envy toward the girl. So, in short, the exploration of this patient's reactions to me as being a murderously envious mother was much more pertinent than would have been any effort on my part to protect her from the dangers of her ward environment. Another common, integrally related error is to fail to grasp how very powerful and how very distorted are the patient's transferences to one. It has taken me a good bit of time in this field to come to realize how very far the patient is from perceiving me as the healthy, strong one in the relationship, and how very much caught up the patient is in transference to me as being the personification of the depressed or very crazy or very inadequate parent of their childhood. The schizophrenic patient is deeply convinced that he is more mature than his therapist, and it has been a very fascinating thing to me to see to what extent the schizophrenic patient is actually trying to help the perceivedly crazy, very sick parent therapist out of the therapist's, so the patient perceives it, illness. These therapeutic strivings on the part of the patient are very genuine indeed, are very loving, and the patient is doing this not only because he needs a genuinely strong parent person with whom to identify, but he is also genuinely trying to help the therapist. And the therapist, in the course of this work, does indeed receive real help. In a sense, only if the therapist can genuinely let the patient be helpful to him can the patient then go on through identification with the help-receiving therapist and be able to receive and use help from the therapist. Another common error is to overestimate the amount, one might say, of conscious thoughts and feelings available to the patient. It is a general misconception that the schizophrenic patient has richer conscious feeling experiences than does the healthy person. In my understanding of it, the healthy person with a much stronger ego, much greater ego strength than the schizophrenic patient has, is really better able to experience intense and conflictual and complex emotions than is the schizophrenic patient. And the patient, as I have been saying previously here, projects upon the therapist so much of the patient's own illness, and in unconscious ways, as it were, puts the feelings in the patient's unconscious, puts these into the therapist. It has been a recurrently amazing thing to me to see that a patient, for instance, who radiates loneliness is unaware of feeling lonely, or a patient who radiates terror is unaware of experiencing terror. Likewise, with a patient who seems manifestly so filled with despair, actually has not sufficient ego strength to be aware of this despair, and only after much treatment starts to become able to really experience the despair. A maddeningly difficult Schizophrenic woman used to hold out her hand as though she had a hat in it filled with little slips of paper, and she would derisively invite me to guess, as if to say, to guess what she was thinking. Only after a number of months did it dawn on me that she was quite helpless to know what she was thinking, and was utterly dependent upon my making some correctly perceptive guess. Another common error is to assume that words mean the same things to the patient as they do to oneself, to assume that the word one is using has the same connotations for the patient as it does for oneself. One sees this particularly as regards the word crazy. A Schizophrenic woman said to me, seriously, she said, "Dr. Searles, do you think I'm crazy?" Now, in a mistaken effort to be candid, I said to her, "Yes, I do, but I regard it as something we can help you get over." I quickly added. I think all she heard was the yes, and this, in retrospect, seemed to have confirmed her fear that she was a hopelessly incurable sexual psychopath, all of which I had not realized the word crazy connoted to her. Another patient with whom I handled this matter better asked me, "Dr. Searles, do you think I'm crazy?" And I asked this patient, a man, what he had in mind, and he explained, "Well, sometimes I feel as though there is a steel band around my head." Now, this led to very useful further exploration. But again, would have had no way of knowing that the word crazy had that kind of bodily symptom connotation for him. The next point I want to make is that I have found it very, very reassuring at seeing how I have prematurely concluded, have assumed that I have made an error with the patient, that I have done something anti-therapeutic, only to find, lo and behold, that the next day the patient is doing better than usual. Where in my work this is most often seen is that I will feel at the end of one session that I have been destructively harsh to the patient, that I have been too frank, that I have confronted the patient with feelings on my part, that the patient is too fragile to stand, only to find the next hour I have with the patient that the patient is working much better than usual. Again, this has to do with my own tendency to underestimate the strength of the patient and his resiliency. The last common error I want to describe is that of assuming that silence in the psychotherapy is a kind of time out from the therapy, a kind of nothing happening in the therapy. Quite the contrary. I have found time and time again that the deepest favorable changes that occur in the patient occur in a setting of silence. And with some of the more ill patients, I have found that several months of predominant silence may need to occur before the patient can now start using words and start hearing words from the therapist with a genuine feeling of meaningfulness. It is as though previously in their experience, words have been primarily defensive, have been barriers between themselves and the other person, and now words come to have acquired a genuinely communicative meaning, fused with and linked with nonverbal emotional meaningfulness. It is as though the patient has now traversed the era from the nonverbal period of infancy and early childhood into the verbal era, and this time has done so in a healthy, genuinely meaningful fashion.